Well, hi everyone, and I'll just get the ball rolling now. I'm assuming there'll be a few people who will dial in a little bit late. So just to start with a few housekeeping rules. So hello everyone and welcome to the Prototyping for Patient Benefit event. First of all, I'll have to go through some of the points to make sure that the event runs smoothly. So if you aren't muted, can I just make sure that everyone's got their microphone muted and just the cameras turned off during the talks, just as not to interrupt the speakers. If you are speaking, you can obviously turn your microphone on and your camera on as well if you would like. Can I also advise everyone that the event is being recorded as well, and that'll be shared with you after, and some of the people who can't attend who expressed interest in this. There's also going to be a chance for questions and answers. That's going to be after each of the presentations. And if you would like, can you utilise the chat box for any questions which you may have, and I can present them to the speakers. And now on to the introductions. So welcome to the Prototyping for Patient Benefit talk, which will hopefully be the first in a series of events which will shine a spotlight on the innovation pathway and how we progress innovation within the Trust, with real world examples from our fantastic frontline staff who have worked on them and can help to provide you some more information, and hopefully to inspire those of you who might have an idea to see that it is possible to take the idea through to getting something that can make a real positive impact on healthcare and patients. There's a great cross-section of the types of prototyping which we have undertaken as a trust, with Caroline Rudland covering what medical physics can offer, and give a great example of them working with a team internally to help solve a problem. We'll also have Dr. Mohammed and Dr. Dowson, who have worked together with some help from industry to help develop a shoulder bench, which a few of you might have seen in the local press. And they'll be taking you through their journey. Dawn Lockey as well, looking at how her and fellow limb reconstruction physiotherapist Helen Johnson had identified a need in the market and had worked with one of the universities in our region to help develop a prototype. And last but not least, we'll also have a team from the University of Sunderland led by Tony Alabaster to help discuss what the university are doing in this sector and how they can assist with prototyping for patient benefit and healthcare in general. Each talk will be about 15 to 20 minutes, but as mentioned, there's going to be some time for question and answers after them. We'll also need to add a little disclaimer as a word of warning. With this being prototyping for healthcare, there will be included some videos or photos of medical procedures just to highlight this prior to the talk. I'm sure our speakers are going to mention it as well if the next slide will contain anything which might be of note for anyone who does not want to witness these. So obviously now to hand you over to the real stars of innovation and who is all here to listen to talk about their experiences. And up first we have Caroline Rudland from Medical Physics.
Hello, thank you for asking me to speak today. My name is Caroline Rudland and I work in the Medical Physics Department here at Sunderland Royal. Today I'd like to speak to you a little bit about what we do in medical physics and also introduce one of our projects. Have you ever wondered what we do in medical physics? Is there more to it than clinical nuclear medicine? Well, yes, we work across 3 sites, the Queen Elizabeth Hospital in Gateshead, South Tyneside District Hospital and Sunderland Royal Hospital. All 3 sites have nuclear medicine, with South Tyneside and Sunderland also providing bone density services. Here at Sunderland, we also have clinical instrumentation, physiological measurements and computing. This is where I'm the lead clinical scientist. My background is a degree in engineering and a master's in medical physics. So what can we help with in medical physics? Well, a large part of my role is to work with clinicians and other hospital departments to develop innovative solutions where there is currently no commercially available one. Often, projects involve taking a physiological measurement and transforming that into an electrical signal to be displayed either locally on a computer, but not always. Here are a few of our previous projects. This first one is where we worked with speech and language therapy on a device to measure tracheal air pressure. Pediatrics, to try to measure height of a child without touching them. Another one with speech and language therapy to provide a natural voice recorded communication aid, which is simple to use and can be connected to a telephone. the neonatal unit and the CHS charity as it was then, to enable people to donate easier by adding NFC. And also audiology, where we've provided 2 visual reward aid systems for testing both children and adults with learning disabilities. So you can see we get involved in quite a few different areas, and that's what makes the job so interesting. But today I'd like to focus on a project with the chest clinic, the 6-minute walk test. Unsurprisingly, this is used to measure how far a patient can walk in 6 minutes, to assess their ability to walk or exercise. During the test, the operator measures their oxygen saturation and heart rate. And before and after the test, the patient rates their breathlessness and leg fatigue. The standard method across the country is for the patient to walk up and down a corridor carrying the pulse oximeter, and the nurse or physiologist noting the oxygenation and the heart rate at the end of each lap, causing the patient to slow down to show the screen to the operator. In some cases, particularly in the past, the operators had to carry the equipment for the patient and walk alongside them, which influenced their walking speed. When you're glancing quickly at the oximeter as the patient passes, it's easy to make a mistake when you're writing the values down. And collecting the data at the end of each lap results in sporadic and difficult to visualise and interpret data, not helped when at that moment the oximeter has no signal. So what were our aims in developing a new system? Well, we wanted to collect the data automatically and more frequently, to see the data trends graphically as the test progressed, to allow the patient to be self-paced, to allow the input of patient demographic data, noting the ends of each lap and any rest periods that the patient might take, and to provide all of this on a printout for the patient record for the consultant to review. And this version ran well for many years in the chest clinic, but recently we updated it. The new requirement was, instead of the paper printout, which had to be scanned to upload to the hospital electronic patient record, to have a PDF output so that it could be uploaded directly. This required not only providing that PDF, but also changing from a standalone Windows XP laptop to a Trust connected laptop, which required a hardware change from a serial connection to the more modern USB connector. And whilst we were doing this, we opted to add some feature improvements, including the pre and post walk test monitoring, and using the status data from the pulse oximeter to give a better understanding of the reliability of the data. So our system consists of some patient electronics, including a commercial pulse oximeter, wirelessly linked to some PC electronics, and some software, which can print the report for the patient notes and for the consultant to review. And we designed and put together the electronics and designed and wrote the software with various testing stages during the prototyping. When we updated the system, the areas in pink are the sections that we had to update, which were the PC connected electronics and the software, and enabling the data to be saved as a PDF for upload directly to the hospital patient record for review by the consultant, and the software provides instructions for the operator at the bottom, which has been welcomed. Here are 2 videos which compares the traditional approach on the left with our new approach. You can see Peter here explaining the test to the patient. At the end of explaining, he takes the pulse oximeter and heart rate measurements. A single reading with the traditional method, but over 30 seconds with our system. And he also asks the patient to rate their current breathlessness and leg fatigue scores using a Borg scale. Once he's got all this data, then he asks the patient to begin walking. As the patient walks around the cones, traditionally the operator has to read the pulse oximeter as the patient passes him. you'll see that this causes the patient to slow down. It also results in infrequent data, whereas with our system, data is collected every second and the laps are marked on a graph by pressing a button at each end of the lap. I'd like to give a big thanks to Peter and Katie for volunteering to be recorded. So this is the output from the traditional approach. As you can see, if the patient doesn't walk very far, then there's very little data to go on. And even if they do many laps and have more data, it's quite difficult to visualise what the numbers actually mean. In order to demonstrate this, hopefully more clearly, we took one of our recent patients and have recreated what the paper results would have looked like, so you can do a comparison. So if you look carefully at these numbers, you'll be able to see that actually the oxygenation level decreases and the heart rate increases before a little recovery and decreasing again. And the post-test measurement suggests some recovery too. If we were to graph this data, hopefully you'll agree that that gives the information more clearly and it's easier to see what's happened. But there's still no time indication, and where is that rest period? So what I did was I took these data points and actually plotted them against time. So now you can clearly see where the rest period is. And in actual fact, we can put in how long the rest period was because we have that data from our system. So I think you'll agree that this shows much more clearly what's actually happening with the oxygen and heart rate levels. But what about if we could add more data to this? Would that help? Hopefully you'll agree that by graphing the data every second, it can build up a better picture of the patient's SATs over the test period and how that actually relates to their walking. The pre and post walk rest phases allow an understanding of the rest data rather than just taking a single measurement. You can see here, particularly in the post test, where the heart rate is recovering and the oxygenation rate is saturation is recovering. We've also set it up to be able to compare with predictions from literature and to provide some summary data for the rest and walk phases. Next for the 6-minute walk test. Well, we'll continue to monitor its use and collect feedback. Some of the favourite features that have been mentioned are the continuous monitoring of the oxygenation, being able to monitor the walking pace, clearly showing the rest periods, and everything being plotted digitally. No more paper. The most requested feature is to add a perfusion index measurement to allow us to determine the accuracy of the oxygenation measurement. One of the general comments, which I think showed that we are meeting our aims, is that it's a big improvement over the old method with very clear presentation of the data. We hope to be able to extend its use to the team at South Tyneside and also look at whether it can be used elsewhere. So what's next for medical physics? Well, it's your opportunity to help decide. Have you got an idea or a problem that needs solving? Do get in touch with either me directly or the innovation team. And finally, a big thanks to the chest clinic and pulmonary function for all their work in this project. And also to Peter and Katie for agreeing to be videoed. Thanks for listening. And has anyone got any questions? No? Okay. Thank you.
Will be Dr. Mohammed and Dr. Phil Dowson looking at the shoulder reduction bench. So over to you guys.
Hi everybody. I'll be doing this live with Ala, who's also online, so hopefully we shouldn't have any pre-recorded issues. My name's Phil Dowson. Ala Mohammed is with me, who's going to take through some slides later on, and we're both emergency medicine consultants at Sunderland and South Tyneside, who over the last few years have been working on a innovation project trying to improve quality of care for patients with shoulder dislocations. So I'm just going to give you a little bit of background. If we could get next slide, please. So shoulder dislocations, as are shown in the X-ray, there is where the humeral head, the humerus being the main bone of the upper arm, or the only bone of the upper arm, comes out of socket, out of joint where it should sit. It's one of the main, or it's the most common large joint dislocation that we see in the emergency department, and it's the sort of injury that you probably know about either yourself or know someone who's suffered them in the past. And it's extremely painful and debilitating injury that needs to be treated as quickly as possible, because your arm simply can't function unless properly, unless that what we call ball and socket joint is back in place. So it's really important that we treat these as effectively as possible. Next slide, please. So this little flow chart shows the numerous different ways in which shoulders tend to be treated when you present. This is specific to our emergency department, but it's probably similar across most emergency departments. The patient presents to triage in the blue box at the top left. Our triage nurses are very experienced, and it's very straightforward to spot a shoulder dislocation early. So these patients tend to be highlighted to a practitioner, either a doctor or one of our emergency practitioners, and they tend to be highlighted quite early on in the patient's journey, because we know how painful it is for the patient and how important it is that we get that treated as quickly as possible. So the practitioner will normally make contact with that patient fairly early on and organise an X-ray to confirm the diagnosis. And then after that, a number of different ways, or there are a few main different pathways which the patient can take. So in our emergency department back in 2016, when we first started looking at this data, because we were aware we might have a bit of an issue, we found that the patients were either getting treated, once the X-ray was confirmed, treated by that first practitioner that saw them, who would give them some pain relief, some gas and air, maybe a bit of morphine, and would do one of a number of different procedures. There's about 50 different documented techniques for reducing shoulder dislocations, and there was a lot of variance in practice, but some patients would be treated there and then by the initial practitioner seeing the patient. More commonly, that initial practitioner would be a emergency practitioner and someone that was either came from a predominant nursing background and didn't do a huge amount of procedures like shoulder dislocations. So they would often be handed forward to a senior doctor, either a registrar or often a consultant, to do that procedure, which is obviously an extra step in the journey that the patient could do without. But then more commonly, it was assumed that because this procedure is painful, and there was a culture in our department that all of these shoulder dislocations had to be sedated to have their shoulder put back in place, which isn't the case, but it was something that we were doing quite commonly. So the most common route was that the patients were then, from having their X-ray confirmed, were going straight to a monitored bed, with being given some potent anaesthetic drugs to sedate them, and then a senior doctor, as well as another practitioner to manage the sedation, and another member of nursing staff to monitor the patient, were all involved in then reducing the shoulder under sedation. And then once the shoulder was reduced, they would recover, go back to X-ray to confirm it was back in place, and then after further recovery from the sedation would then ultimately be discharged. If any of those steps failed, then the patient would be admitted. Next slide, please. So, and these are the percentages of how those patients were being managed. So this was back in 2016. So we had 57% of our patients were being sedated for their shoulder reductions. 27% of them were being seen by an initial practitioner, normally a care practitioner or a junior doctor, and then immediately said, this patient has a shoulder dislocation. I can't treat that personally, so I'm going to hand over to a senior doctor. So 27% were being handed over to a senior doctor that would sedate them, reduce it without any sedation. And then finally, 16% of the patients would be seen by that initial practitioner and treated at the point of contact with Entonox, a little bit of morphine, and reduced without sedation. But in those cases, that initial practitioner that came in contact with the patient was almost always a senior doctor that had just been grabbed at the right point early on. Next slide, please. So why is that an issue? It was an issue, it felt to be an issue for a number of reasons, because certainly from my personal experience, having reduced lots of shoulders over a period of time, I've found that actually it's the minority that you need to sedate. The vast majority can be reduced with different techniques, some simple pain relief, some anxiolytic like gas and air, and can be reduced relatively straightforwardly without the need for sedation. And that's certainly backed up in the literature. Certainly in some countries, they don't use sedation at all for shoulder dislocations. They will just do them under simple pain relief. And when you start to introduce sedation to do these procedures, you introduce an element of risk. There's a 4% risk of adverse effects from procedural sedation. You also introduce a number of extra steps in that patient's journey. The patient needs to be in a monitored bed, and as I'm sure you're aware from the pressures that the emergency departments in the country are under, monitored beds are in short supply and are really valuable. And the longer a patient stays in a monitored bed being sedated, the longer another patient has to wait to be treated. And then there was also the element of senior doctor time. So once you start introducing procedural sedation, that is a relatively advanced skill for the emergency department and normally relies on a emergency medicine consultant or senior registrar being involved to make sure that sedation is done safely and fully monitored. And it requires additional nursing staff to meet the Royal College guidelines on how to do safe sedation. So 57% of patients for a relatively straightforward injury to treat seemed like quite a lot and quite a concerning number. So it highlighted a problem that we needed to address, and we started thinking about how we could improve the experience of these patients and our experience as a department. At which point I'll hand over to Ala, who will talk you through the ideas that we had and how that progressed.
Yeah, thanks, Phil. Yeah, so it's kind of after we identified there's a problem, we clearly needed a solution, and so the problem we kind of felt is there's really less than satisfactory management of a fairly common presentation to the ED. We often see on an average maybe two a week, so about 100 cases a year. So anyway, so we start looking into what evidence, what alternatives are there. Really techniques under which you can reduce the shoulder without the need for sedation and factors which Phil already mentioned. So then we started studying some evidence and what papers are there, and we came across the Oxford chair and the reduction technique, which has already been prescribed before, and some countries had some studies where they found it kind of easy technique to teach and and retain the technique once you learn it. So it's not really heavy, it's not senior dependent. So once you train your staff, they easily can retain the competencies once they've done it. So it seemed that Oxford technique ticked all the boxes which we were looking at. So we thought, okay, brilliant. Let's get in touch with the guy who made the first bench, which you can see in the photo on the right, top right. So the guy was quite helpful. He works in Oxford area, and he was quite helpful. He gave us all the dimensions of his bench, but what he said is number one is not commercially available, which okay, and number two, and he said, which that's where we kind of felt, oh, there's maybe a room here for some innovation or some improvement, is that they wanted to make the bench sturdy. Sorry, they wanted to make the bench adjustable, but they couldn't make it sturdy enough. So that's why they ended up with the bench or the chair they've done. So we thought, okay, that's something probably for us to look at. So next slide, please. So I started looking into what's alternatives and how to be able to manufacture our bench or chair. So initially I started looking at the different chairs where you see in the kind of beauty salons where, but I couldn't find anything which I felt was suitable. And then I thought, okay, the best thing, maybe I can just go to one of the local gyms and see what devices they have and whether anything from there can be adjusted for our needs. So then I came across a different type of bench, not the one you have in the photo, and I bought that and I adjusted it. But that was which I call prototype one. No, not that. Sorry, go back to, yeah. So prototype one, which was a big failure, I have to say. And then I came across this preacher bench, which when I looked at it, it looks very much not dissimilar to the Oxford chair, but just needs some modifications. And its specs specification was quite good. So the one in the photo, it's kind of able to, according to the manufacturer information, so it's able to withstand 220 kilogram on top and CE marked and all of that. So it ticked most of the boxes which we needed. So I thought if I then cut the first bit on the left, where the silver thing, and I reverse that floor kind of support, we probably can achieve the bench which we need. If we go back to next slide, please. Yeah, so we've done that. If you see, so the shoulder, the chest support, I just reverted it. And then we cut the first the part of the front, and then we had this bench which was very much what we needed, and then adjustable, so you can raise the seat up and down, and you can raise the chest support up and down to suit your patient and the size of your patient. So me being naive, that's into that field, that's okay, ready, we should go and start working on it. So next slide. So I thought, okay, let's go and use it on our patients. And I was told, no, wait, we need to present it and have an agreement through our clinical governance meeting. So, okay, we presented it. And again, being very naive, I thought, okay, now we have the green light to go and use it. But they said, no, we need to check then whether our indemnity, somebody trips on it, on all that kind of insurance indemnity. And after a bit of a few hoops, then we got the green light to use it and start kind of publicizing and train our staff into this new or new for the department approach for shoulder reductions. So with Phil, good work. He then did this training video. Next slide, please. So this training video, he then made it and we start training the staff. So if we start the video, please.
Hello, and welcome to this short training video on a relatively novel method for reduction of anterior shoulder dislocations. The modified shoulder reduction bench is based upon the Oxford chair, which was recently subject to a randomized control trial by Chung et al., showing a 72% success rate in reduction without sedation. It forms part of a quality improvement project to help reduce the number of procedural sedations required for shoulder dislocations as well as reduce the time to reduction and time to discharge. The chair itself consists of a seat and angled chest rest. The patient should be positioned on the chair, resting their chest on the cushion pad and allowing the affected arm to hang down on the other side with the axilla over the top of the chest rest. The theory is that at this angle the patient's muscle groups struggle to contract against gravity, and in this position the issue of tractional and counter-tractional direction is taken out of the equation with only some very basic manoeuvres required, making it easy to learn and perform. The procedure should be performed only on patients with confirmed anterior shoulder joint dislocations with no associated fracture or vascular deficit. The patient must be mobile and compliant in order to position themselves adequately on the chair. They should also have been offered some analgesia, such as IV morphine, allowing up to 20 minutes for this to reach peak effect before reduction. With the patient positioned, the first manoeuvre is to provide traction vertically in line with gravity. You may feel the arm start to gradually relax and drop down. Whilst maintaining this traction, the next manoeuvre is to slowly externally rotate the arm. You may feel a clunk, suggesting that the shoulder is back in joint, at which point support the arm and gradually bring it back across the body. Here is a video of the technique done in real time on a patient.
Bring your shoulder right over the top. Okay, that's it.
Isn't it?
Yeah, that's it. Okay. Just remember we're videoing, so don't swear. Okay, just stay there for a second. Alright. Now I'm going to sit you back upright and gently, okay? Just nice gentle movements because we don't want it to pop back out, okay? So, sit back up for me. Now bring your arm across the front. Lovely. And then just hold it there. Okay?
So by this stage now we had a bench, we had a good video which to show, and we tried it ourselves. So we very much more confident it works. Then we had a very clear pathway, what kind of patients who will be suitable for this to be used on the bench, like, you know, fully mobile, what we call anterior dislocation. So, and there's no fractures, so it's a pure dislocation. And then the approach is giving them analgesia, and then with the gas and the reduction. So, and then the training started for all the junior staffs, and particularly the nurse practitioners, who are kind of, which we rely on them quite heavily in our department. So if you see the same kind of pathway we were looking at, fine. So what we have now, the same first step is triage, and the nurse picks them up as clinically dislocated. So then quick initial practitioner contact. So then they get sent to X-ray, and now there's confirmed the third blue slide box at the top. So now we have a shoulder dislocation confirmed. So instead of going all the way through monitored bed or handing over to a senior staff looking for a monitored bed, they just straight away go into that technique, and they attempt reducing the shoulder using the bench. And then once it's reduced, they X-ray basically they confirm the reduction with an X-ray and then straight away discharge. So you can see how the journey gets shortened and the time gets cut significantly. And more importantly, not needing sedation, basically not needing any delay unnecessarily. And if for whatever reason the shoulder cannot be reduced, because there are certain ones you won't be able to reduce it, so they need further input from us, which is sedation. So if you go to next slide, please. So you can see by we start collecting data, and then the data showed significant reduction in the needs for sedation. And if you see almost like 4 out of 5 patients, so almost 80% of patients had a successful reduction using this technique and the bench. So now we start looking into, okay, fine. So we try this bench. We know it works. We know its adjustability helps a lot, because then you can adjust to your patients, different sizes, different weights. And then we start looking into, okay, we're probably going to need to expand here further and start like into manufacturing or more of design improvement, and more, because the more we used it, the more ideas we have in terms of how to optimize the bench. So we start having some meetings, and here we had some meetings pre-COVID, and then, as you'd expect, early COVID, everything was kind of put on hold. But then early this year, that's where things significantly changed, especially with the more pressure on the emergency department, and the more the more need for avoiding things which makes patients more at risk of COVID, like sedation and needing monitoring bed and needing clinicians time. So then we managed to secure some funding, and then we start having regular design meetings with Paul Marshall. So next slide. So by this stage, we had very clear idea what we think the ideal bench will be, because we trialed the one we already have in place over like at least 18 months by now. So then what we wanted really a bench where have easy patient access. So the ideas initially came: is it like W shape or like reverse use at the top left? Or like a cross kind of design, or a double H design, or an X design. But then we opted for a different one, which you will see, because what we really wanted is an easy access to patients. And the other thing which we really wanted, sorry, next slide, please. The other thing which we really wanted is the bench to be very portable and easy to move from one part of the department to another, without the risk of people getting things wrong once they move it. So if you see the chairs, we opted for a design where if it's put on the floor, then it's not mobile. We don't need to lock any wheels or anything like that. But if you want to move it, you just need to lift it, and then the wheels comes into place. So kind of simple things, but the least needing intervention, I guess. So it's like a foolproof. And then again, we discuss about the seat itself, the shape of the seats. Does the patient kind of slide forward, backwards, and so all that came into. We were discussing all that different things, and the most important thing, or one of the important things as well, is we wanted it to be easy cleaned and kind of infection control compliant. So if we go to next slide, please. So if you see so we kind of had to look into different heights of patients and different weights, so going into the 95th centiles of weights and heights, so different testing in using the kind of computer dimensions. And then once we had the initial kind of bench, if you see the top right, we put some weight, I think 200 plus kg, just to make sure that's the welding and the mechanisms, it's safe and sturdy enough. And then we go there with 2 benches, which you can see in the photo down to the bottom right. And then one bench we just already started using it at Sunderland Royal Hospital, and the second bench is will be taken across to South Shield to be used there. But what we felt, rather than rushing things, because I think it's safer not to rush things with these things. We just wanted to make sure, although we were very much confident it will work, we wanted to keep it at Sunderland for us to use it, feel it safe, and then we will move it to South Shield. And now so far we have used it, and we're quite happy with the way it works. So hopefully the next couple of weeks or so, we will take the second bench to South Shield and start training and all that process again in South Shield. By this stage, I'll pass you back to my colleague Phil. Next slide, please.
Yeah, so thanks, Ala. Essentially, from there on, it was about publicising our bench and our success. Really, I think we now had a reproducible model that had been formally tested, and with the help of computer-assisted design, we're able to use that in the, as Ala said, the 95th centile of patients' weights and sizes and heights. So this was now something that we could potentially reproduce it for South Tyneside, and ideally then look beyond that and see if we can benefit trusts and, more importantly, patients elsewhere by providing more efficient and safer care for patients with shoulder dislocations. We did that in a few ways. Initially, we've presented a poster nationally to the Royal College of Emergency Medicine annual scientific conference, which is in the top left. The innovations teams worked tirelessly with the media side of things, and we did some local press publicity as well. And then we're lucky enough to be selected as finalists for the Bright Ideas in Health Awards, which is tomorrow night, which should hopefully publicise our innovation a little bit more. Next slide, please. Excuse me. So what did we learn from all this? A number of things. It takes time. So 2016 when we first highlighted the problem, and so that's been 5 years of working, and it will start and stop. You'll have times when you think things are going very, very quickly and moving at a good pace, and then you'll come up across a speed bump that you won't be able to see the end of. You need to ask for help. I was very new to the whole idea of innovation. I was new to a lot of aspects of how things work within the trust outside of the emergency department. I never get outside the four walls of A&E. So to find that all these collections of people and departments who are skilled and experienced in doing things like innovation, data analysis, and accessing funding and interacting with other organisations was a fantastic learning experience for me, and I will certainly not shy away from asking for help sooner with my projects, because the trust has been very, very supportive in that. Funding opportunities was difficult. I think you have to take funding opportunities wherever you can, and never say no to an opportunity that might lead to some funding, because it might not be in the same format that you'd originally thought. You might need to look at how your project qualifies for that funding. In our case, the COVID funding, there was very clear indications for how it qualified, which we didn't think about to start with, but once we thought about it, we thought actually this is a perfect way of trying to access some funding to move the project forward. And again, ask for help with others from that point of view. A&E is a world of marginal gains. By that I mean, you're not going to change the world with a single project. You're not going to suddenly solve bed weights, bed pressures, safety risks with a single project or a single idea. It's all about trying to improve the experience of the patient in incremental small ways, and this was good for getting those patients treated quicker, getting them discharged quicker, and then for the wider departmental point of view, it was better for the other patients in that we had more bed space available in the monitored areas for our high acuity patients. And the other thing is, I think we take it as all part of the job, and we do these things because we are passionate and enthusiastic about improving things for the patients. But don't be afraid to take pride in those achievements and publicise them. I think Ala and I had probably been a little bit standoffish in that aspect because we were more focused on, just trying to get better results for our department and our patients. But I think seeing the benefits that publicising it has in terms of moving the project forward and benefiting people outside of your trust potentially has been great. So that would be some of the learning points that we've taken from that. Next slide. I think that's it from Ala and I. We're happy to take any questions that you might have, and thank you very much for having us along to speak.
Thank you.
Well, thank you very much for attending. I think it's a great example of how you've identified a problem, utilised sort of cross-sector, looking at potential solutions, co-working, making your teams aware of what you are doing in innovation, importance of all the data collection, and now actually seeing it through to real world benefits. So it's so that's a great example. Imran, did you have a question?
Mark, thanks, Phil and Ala. We haven't met for some time, and congratulations for going this far. I know it's been 5 years. You guys have been persevering with the whole thing, and it just tells you how these things can sometimes take this long. Congratulations also for the Bright Ideas and Health Awards. I'm hoping that your department, after seeing this, we will see more stuff coming from you guys. Hopefully you'll be advertising within the ED department. Just a quick question after that is, how many shoulder dislocations do you see, and is this something that the Oxford bench you were talking about, would they be interested in doing something with you guys, or is that a completely separate bench that they are using within their ED?
So I can, from the figures, I think probably Phil will know exactly how many cases we see a month. So I'll let Phil answer that part of the question.
Yeah, figures wise, it varies from week to week, but on average, we probably see about 3 or 4 shoulder dislocations a week.
Yeah, so it's roughly around 100 to 150 on an average, maybe a year, if not more. In terms of Imran, your second part question, no, actually, it's a good idea. We've not been in touch with the guy who've done the Oxford chair. As I said, the technique is there. The technique is already being described, but he was quite instrumental in terms of making the bench, and he was quite open in giving us all the dimensions. But you raise a very good point. I think probably now we reach this stage, I can't see any harm of getting in touch with him and showing him our results and maybe having a combined dialogue. I think it's a quite good point you raised.
Yeah, thank you. I mean, we are protecting the design rights of this particular device that you've created, so it's actually in the process at the moment, and it's really just trying to see how we can progress this. I'm sure you've got connections, and I was just also thinking it's not just the hospitals, is it? You're also looking at different areas, especially sports. Getting in touch with the local stadiums, or I don't know if there is where these things happen. I didn't even know how common this is.
I think certainly in rugby, in professional rugby, they often have physios trying to treat shoulder dislocations acutely, just in the treatment rooms behind within the stadiums at the higher level of sport, where they've got their own medical teams on site. So that would certainly something I'd thought about as a piece of kit that could sit in the corner of a medical treatment room in professional sports arenas. Yeah, no, and I think it's a very good point you make about going back to the original Oxford chair design. It's not something we'd thought about, but I think is probably something they would like to hear about and see if we can work together to take it forward.
Yeah,
absolutely. Thank you. Thanks, Mark.
Thank you very much for that. We'll have to move it along now. So if there's any questions for them, if you just want to send them through to myself or the innovations team, we'll field them through to the shoulder bench team. Because next we've got, I think we've got half an hour left with them to talk, so we might be a little bit over, but we'll move it on to next one. Yeah, so this is Dawn Lockey and Helen Johnson, who will be talking about their innovation and prototyping experience. So we'll hand over to Dawn, who's here.
Hi everyone, thanks Mark. Can everyone see the slides? Yeah. So my name's Dawn Lockey and I'm a physio in the limb reconstruction team at Sunderland Royal Hospital, and myself and my colleague Helen Johnson have been on this journey with a frame shoe for patients wearing an external ring fixator device using the Ilizarov principles of treatment. So I don't seem to be able to move the slides on. There we go. Okay, so we manage patients with the Ilizarov method for conditions such as limb deformity correction, limb lengthening, fracture reduction and healing. They're generally patients who come with quite severe injuries, and very often the patients wear a frame which extends from the tibia and covers the ankle. It's called an ankle spanning frame. And as you can imagine, the issues that we have with trying to rehabilitate these patients are quite tricky, because patients often struggle to weight bear. The device covers the part of the foot, and we struggle to get a shoe on. They're also in the device for quite a long time, so patients could be in the device for 6 months. We've got a gentleman at the minute who's had a frame on for over a year, so it's quite a long haul. And these are some examples of what we might see. So you can see there that all of those frames extend across the ankle joint, and it makes it really tricky to put something on the bottom of that foot. So in order to heal and for patients to get a good outcome from the procedure that they've had done, they do need to weight bear and place normal stress through the limb. They've usually got a fracture or an osteotomy site which needs load in order to heal efficiently. We also need patients to weight bear in order to maintain soft tissue compliance and muscle function. The frame and pin site position makes it really difficult to weight bear and place a shoe on the foot, as I've said, and often unsupportive and poorly cushioned footwear results in pain. And if patients are in pain, they just won't walk on the limb. So we do have a real challenge. Again, that's another example. You see that the left picture there, that frame actually was almost brushing the floor. It was about a centimetre from the floor. So it's a real challenge to try and get weight through that foot in order to enable foot progression. Currently, we had a look at current global practice, and most people do the same as we currently do. They just use a plaster shoe, strap something on the bottom of the frame. It's very Heath Robinson, and there aren't really any defined criteria. We just put on what we can get on, basically. It's often quite time consuming as well. We can sometimes spend an hour trying to fit something on the bottom of a frame. So it's time consuming for us and the patient, and it makes patients spend a lot more time with us in an outpatient environment. So we do need something more efficient. We did a little bit of market research, and there are a couple of devices on the market to try and get around this problem. The two devices which are currently available are the Smith & Nephew rocker, and what happens with this device is it attaches to the frame, so it doesn't allow the patient to perform normal heel-toe foot progression. It's an external device, So the load that's being transmitted through the frame is actually through the frame and not the limb. So it helps the patient to get the foot on the floor, but it doesn't really encourage normal weight bearing. The other thing is an excator. And again, this is something that's being trialled at a couple of centres. It attaches to the frame rather than the foot, and feedback is mixed. Patients find it quite cumbersome. It's got to be deflated every time the patient sits down. It's time consuming to put the thing on and take it off, and it's quite heavy. So both of these devices aren't really solving the problem that we have. And this is just an example of what we currently use. You know, strap a plaster shoe on, stick some silicone inlays in to try and make the patient comfortable. It's not a great solution. So that is quite a good example of something that we might fit to the patient's foot. It doesn't look too bad there, but when the patient starts to walk, you can see that posterior strap, that white strap at the back there, that tends to just slide around. The shoe doesn't stay on the foot. The patients feel quite unsteady. So we had to think about what we thought we needed, and we came up with what we thought was a start of a solution. So we thought we needed perhaps a custom device which considered the frame complexities, something which attached securely to the foot or the frame, but which avoided pin sights, because pin sights, the wires go right through the patient's limb, and pin sights can get really sore if you put a lot of load or pressure on them. So we do need to look after those. We need a device to be made of materials which provide comfort, and from the experience which we've had with other cohorts of patients, we considered a rocker bottom shoe as being helpful, because if you have an ankle spanning frame on, the ankle joint is very often fixed. So we want foot progression, and we want ideally a heel-toe gait pattern, but that's impossible with a fixed ankle. And a rocker bottom sole really does help that. So they were our initial criteria. And potential benefits would be improved patient compliance with rehabilitation, a reduction in pain when the patients try and walk, something which the patients don't mind putting on. They hate wearing a plaster shoe. Anything that looks very, very abnormal and is tricky to put on and take off, patients really don't like. Hopefully, if we can help the patients to weight bear and load the limb earlier and in a better fashion, we'll have quicker healing times, and these frames, which can stay on for 6 months plus, will hopefully be removed more quickly. And it'll save cost. Certainly our time spent to try and put something on the patient's foot, that's one cost saving. And time to the hospital, having patients who have a delayed frame removal. So the journey started with this. We attended a rheumatology and R10 funding call application for an unmet need, and we put in an application in 2019 in March, and very, very luckily we were awarded £5,000 a grant from the HSN, and we had support from our innovation team at South Tyneside Sunderland Foundation Trust immediately. The innovation team at our trust helped us to look around for partners to engage with, and we did look for almost a year, 9 months to a year, before we found the innovation design team at Northumbria University. So 2 members of the team up there, Matteo Conti and Marco Silvetti, immediately when we met them, we fit really well. They understood what our needs were. They went off and tried to design the shoe, and they produced a CAD design of the shoe, which was really, really helpful. The next step was to try and produce a prototype. So I'll move on to that in a second. But while we worked with the design team at Newcastle, we met and had multiple workshops. We did some market research and we mapped out the process. We went back and forth. A lot of the meets were on Teams or Zoom calls because, again, COVID hit in the middle of all of this. But very fortunately, the guys at Newcastle were keen to keep the project moving. And I think because the students weren't on site, that was actually an advantage for us. We had a little bit more dedicated time from them. So this is just some examples of our our ideas of what we thought we needed, and then the guys came up with some initial drawings of our ideas really, and we went through the process together. So the next step, we had the CAD drawing. Unfortunately, the Northumbria team couldn't produce the prototype. Again, it was mainly because of COVID. They didn't have access to the equipment. So our innovation team again had a look around for support, and Nick Moore from the Innovation Super Network did a scope of practices regionally and found a distribution partner in Podfor, which is a biomechanical inlay company which are attached to Peacocks, and they're a local company based up in Newcastle. And again, once we met with Peacocks, they used the CAD drawings that they developed and improvised, and they produced the initial prototype for us. So the prototype was developed and made from materials which we perhaps won't stick with in the long term, but it was really useful to get this prototype for patients to try, the feel of it, the look of it, the practicality of it. And that's what we're using currently with patients. So we've done a little bit of prototype evaluation. First of all, patient feedback. Patients seem to really like it. The rocker bottom, both fed back and said this was really helpful, and they've had long-standing problems with their ankle, both of these patients. It has a soft silicone inlay, which patients find really comfortable. It has an anti-wick property, so there's no sweating. Actually, the two patients who've trialled this have had, they're both diabetic patients, and they've had no skin complaints or issues at all. It takes, it anti-wicks the skin itself, so there's no irritation. The straps are made of bamboo too, which are really helpful. One of the patients wore it all day, every day since he got it, and he found it no problems at all. There were some glitches from a comfort perspective. One was that one of the patients had some metalware removed from the plantar aspect of his heel, which was a very painful area anyway, and he just struggled to load initially. One of the patients had an issue with the outer border of the shoe rubbing. It was more an issue with size, because we only had a couple of prototypes to start with. But overall, pretty positive feedback. How it looks and wears, patients seem to like it. Their feedback's very positive. Happy to wear outside as well as inside. It doesn't slip. It seems to stick to the sole of the foot pretty well. It's lightweight. It was produced on a 3D laser printer, and the sole itself is made of, it's a plastic material, a hollow plastic material, but we probably will modify to make it a bit more comfortable for the patients. There was a difficulty with the back strap. It was a bit too loose. It needs to be modified, and the sole being rigid was quite noisy on the floor, so patients complained that it was a bit noisy when they were moving around. From a functional point of view, again, the rocker bottom was really helpful. It takes minutes to apply and take off, which is the big issue for us. Once it's on, it literally takes a couple of minutes. It's just like strapping a shoe on the foot. The back strap's not fit for purpose. We do need to modify that. However, the back strap did seem to improve with patients who had pin sites in certain locations, because we could use the lower horseshoe ring on the patient's foot as a bit of leverage, a lever arm. So it's not always a disadvantage. So from our perspective, Helen and I were thinking about further development of the shoe and how we could perhaps take it forward. And we have spoken to Podfor last week. We're at the stage now where we need to possibly take things forward a little bit more. So we have some ideas ourselves: strap security, adjustable strap location because of where the pins lie, this type of strap itself. And we just pulled together a few ideas. As you can see, these are off different devices and different pieces of footwear and kit. The sole we would like to be modifiable. We need to adjust the height of the sole a little bit more. We have a little bit of play, but we want a bit more depending on where the frame sits. So there are ideas that we have, and the patients have come back with feedback, and the design team at Podfor have also got ideas. So we're still working together. And this is what I've just said. We continue this process, and hopefully if we do find a prototype which at our trust seems to gain good feedback and we think is working efficiently, we would like to try and trial our prototype shoe with other trusts. So that's something way ahead in the future. We aren't as far ahead on our journey as the shoulder bench team. Just listening to their talk, it was really interesting. They've come a lot further down the pathway. And one thing that I personally was surprised by was the lack of knowledge that I had in IP, intellectual property, and MOU agreements and agreements with different bodies and different services. Being completely new to this, and very naively, we just had this idea and thought we could just stick it on the patient, but there's a lot more to it than that, and the process does take quite a long time. So we think we've had a little bit of a think about our device, and we've got a name for it now. It was initially called a boot, but it's not a boot, a boat, custom shoe, frame shoe, but together we've worked out a name, and we've thought about the frame arc, because it's all patients who wear frames, and arc is adjustable rocker kit. So it can be modified for each patient. The idea is that hopefully in future we'll have a kit which has different sizes, for example, small, medium, large, adjustable height, adjustable straps. But the cost of the kit would be kept low because it's still a standard set of criteria that we're going to use, and that's something that we're talking to the team at Podfo about as well. So if there's any questions, that's the end of our talk. Thank you very much.
Thank you very much. Joel, is there any questions? Yeah, Imran?
There's an echo coming over, Mark. I don't know what's going on. Is somebody not muted, perhaps? Don, thank you very much. Very nice presentation. Once again, very inspiring, actually. Your team is brilliant. Very nice name, too, actually. We love the name. You know, we've been sort of talking about internally. I think the Sunderland trust needs to be recognized elsewhere. So we do need to have a South Tyneside sort of little label underneath it so that you are recognized as well in naming these things, but a fantastic name. Just a quick question to you. Where do you find the time to do this? Because you've been doing this for some time and taking this really nicely along with the innovation team. But often the question is asked, you know, especially is for nursing teams, particularly allied health professional teams, how do you get into innovation? How do you gather the time? You know, what do you do personally?
It's, I mean, time's an issue for us all. It's really tricky to dedicate time to anything else other than the clinical caseload. We all know that. But I feel personally that we've had quite a bit of support. The innovation team have been really helpful to us. And once we started on our journey, things continued without us needing to necessarily be involved. You know, the IP agreement, the MOU, the things that once the ball starts rolling, you don't have to attend everything. And, you know, we all commit to things outside of our normal clinical caseload. And if we see an outcome, you know, we've got this shoe, and if these patients get benefit from what we've done, the motivation for our team and the uplift in the department, everyone's prepared to put in a little bit more if there's something that comes back from it. And when we got the first prototypes, put that on a patient, the rewards in that, you know, we're early in the journey, but the rewards in that are huge. So I think that's what keeps us motivated and keeps us going, but the time is an issue, and I think we just have to dedicate some time to it because it is important. Otherwise, we continue with the way things were before. We spend hours putting these rubbish shoes on, and we're going to save all of that time in the long run, you know. So it's kind of a little bit of discomfort now, which will hopefully benefit the future. And this issue with the shoes and frame patients isn't an issue just at this trust. It's an issue across the board, nationally and internationally. We're members of the BLRS, the British Limb Reconstruction Society, and the quick survey and bit of market research that we did at the start of the process told us straight away that everyone's the same, everyone has the same issues. So it'll hope you know, perhaps in years to come it might help the whole service, you know, not just our small team.
Thank
you.
One last quick one from Caroline in the box was, do you have to do anything for the other foot when altering the height of the boot?
Yeah, we've talked to the design team about this. Most often we have issues with the affected limb being short. A lot of these patients have a short limb. If they've got multi-trauma and a malunion or a congenital limb shortening, we don't typically have the issue where when we put a shoe on, the affected limb is longer than the other side. So we don't usually need a modified shoe on the other side. If anything, we want more height on the affected side. So that's how we usually cope with it, by trying to build up the affected side a little bit more.
Thank you very much for that. And one last thing back from myself, good luck tomorrow as well, because you're also nominated for Innovation Champion at the Bright Ideas and Health Awards. So that's be a very eventful night.
Thanks very much. Thanks for letting me speak, everyone. Thank you.
And just to hand over to the University of Sunderland team, just so I don't forget anyone, I'll let them introduce themselves by their names as well.
Thanks very much indeed, Mark, and many thanks to all your colleagues who've given some excellent presentations there today. For us, I met with Mark down here a couple of weeks ago, a face-to-face meeting, just to try and explain the opportunities that we can bring to the table in terms of some of the sorts of projects that you've mentioned today and others that might be in the pipeline. So can Adrian just move me on to the next slide? So my position is I'm Tony Alabaster. I'm Academic Dean of the Faculty of Health Sciences and Wellbeing, but just for the first part of this slide, I'm here also to represent the full spectrum of faculties within the university. And one of those that may be of interest to the colleagues at this innovation presentation is our Faculty of Technology. And I understand the frustration that some of your colleagues have had around trying to find universities with particular expertise, maybe around prototyping, engineering, IT, etc., etc. Just as an example, our Faculty of Technology has got very significant 3D printing facilities, very strong on prototyping, and has produced some excellent materials during the pandemic to help local NHS organisations. So there is an opportunity through the Faculty of Technology, and it's always worth exploring their possibilities. There's the Faculty of Arts and Creative Industries, the National Glass Centre down at St Peter's is part of the university, and we've got significant resource within that faculty. Education Society, Business Law and Tourism may be more marginal in terms of the sorts of things that you've mentioned today, but there is nevertheless significant expertise in there in ways that just may not have been able to think about previously. For me as Dean of this faculty, there are 4 schools in this faculty. Pharmacy and Pharmaceutical Sciences, and the next presentation after my slide will be Dr. Adrian Moore, who's head of that school. The School of Nursing and Health Sciences, which incorporates the Helen McArdle Nursing and Care Research Institute, and Yitka Graham is head of that institute, and she'll give the presentation after Adrian. We also have the School of Psychology, and I think there's already been quite significant input from that school on statistical analyses to some of the projects that have been shortlisted in the Bright Ideas in Health Awards. So they have very, very significant data analysis and statistical expertise, which is often very useful in these types of projects. And finally, as you probably all know, our new School of Medicine. And within all of those 4 schools, there's a range of subject expertise, which I would just encourage colleagues to think about when you're starting to generate the ideas around new innovation projects. As it says at the bottom of the slide, the presentation is within the context of the Research Excellence Framework, the REF, and the Knowledge Exchange Framework, the KEF. There's a third one, which is the TEF, we're good on acronyms, which is the Teaching Excellence Framework, but we'll just ignore that for the moment. And my conversation with Mark is to just try and streamline how these conversations can take place. So for anything that is clearly technology or art or business, Mark will have direct links into their deans of those particular faculties. If it's out and out health related, he has a direct link into me, and then I will liaise very quickly with colleagues here to see if any initial idea has got some traction that we can start to think about and talk about before we then start to maybe talk to legal, and people have mentioned MOUs and IP. So before getting that far down the road, it's very easy these days just to have that quick conversation just to see if the ideas are useful. I'm now going to pass over to Adrian Moore, who'll talk us through some of the ideas that we've been currently working through to see if they've got any traction with yourselves. Adrian.
Thanks, Tony. So, as Tony said, my name is Adrian Moore. I'm head of the School of Pharmacy and Pharmaceutical Sciences, and actually I'm a pharmaceutical chemist by background. And our whole area of research is sort of summarised in the top sort of couple of bullet points, which is to take knowledge and innovation and move it from laboratory research into the development of novel therapies and products, and to somehow come to an evaluation in clinical practice. So what we're always looking to do is try and take our laboratory science-based research and apply it for the benefit of patients, whatever that might look like. And we've got a couple of examples that I'll just talk you through in a minute. And in terms of the expertise and themes, which I'll exemplify, is from laboratory-based molecular and cellular biology, drug discovery and development, and that then moves into devices and digital health technologies as well. So by way of a couple of examples, if you sort of track right back to the starting point of molecular and cellular biology, part of what we do here is look at the pathological disease process and try and understand the mechanisms behind disease and try and understand potential targets for therapies of disease and exploit that as a route into potential treatments. And one of the things that we've been looking at the university here over the last number of years is around cystinosis as an orphan disease. And one of the things that was clinically identified was poor patient compliance, in particular with the current medications. So what we started to look at was the pathogenesis of the particular disease and targets as to how perhaps the disease treatment could be improved. And to cut a very long story short, we have now developed a prodrug which is currently in preclinical trials. It's currently in an animal model, and we're hoping to move that into patient clinical trials in a very, very short period. So hopefully around about June, July time, we're hoping to move that into a patient clinical study. If you then move it on, other aspects are around perhaps how one can better improve medicines for delivery to patients. And that might be around the concept of novel formulations around targeted therapies. And Tony mentioned the concept of 3D printing in terms of devices, but also around the use of 3D printing in terms of medicines. And that has significant application, particularly in the context of personalised medicines, perhaps, and bringing together a number of different medications for a particular patient to manage their treatment disease state. That might also move on to the concept of taking current medications that perhaps patients can't take for any particular reason and move into the concepts of specials manufacture. So we work with a number of the specials manufacturers in the region, looking at what are currently off-the-shelf medications and trying to find different ways of formulating them that perhaps are more amenable to patients that have particular difficulties in taking those medications. So the whole concept around how one might ultimately formulate a drug. And another significant area that we've looked at recently, just as an example again, is around identification of disease. And a significant clinical example has been around the identification and rapid identification of particular bacterial infection down to the particular bacterial disease strain. And that then, of course, optimizes the choice of antibiotic that might be used in that particular patient. So again, we've developed a product that is actually now commercial, but it's come from a starting point of the understanding of the significant risks associated with bacterial infection and not getting appropriate treatment at the appropriate time. And that has actually moved on to identification of chronic infection that might be portable into perhaps a public space. So particular examples are around use in battlefields and things like that, where you need to have significant intervention very, very early doors to actually manage that particular disease state. And that concept of understanding a bacterial identification also moves on to the fact that we can also do analytical methods. So trying to understand markers for disease states. So analysing biofluids to understand potential markers for disease state, perhaps around early identification of disease and therefore early intervention. So that sort of gives a very, very quick overview summary of some of the laboratory applications that we've got that span the whole spectrum of identification and target identification of disease all the way through to potential patient treatment in perhaps slightly different ways to those that are being currently used. Hand over to Yitka.
Thank you. That's great. Good afternoon. See some familiar, can't see you, but I can see your names. I'm Dr. Yitka Graham. I'm head of the Helen McArdle Nursing Care Research Institute at the University of Sunderland. As Tony said, that's situated in the School of Nursing and Healthcare Sciences. The Institute sits very much at the bedside area of the bench to bedside, but there is sort of synergy between the bedside informing the bench and vice versa. I'd just like to talk to you about health services research, which is my personal clinical specialty, and how that can inform innovation. Traditionally, you think some of the people I've worked with in the trust, we've looked at health services research very much through a research lens, but I think the pandemic has presented an opportunity to sort of rethink about some of the ways we do things and sort of disrupt current processes. And I think health services is a good way of sort of looking at it. It focuses on the organisation and delivery of services in health and care, and that's not only in NHS, but it's in health and social care settings. And if we look at the long-term plan, looking at keeping people out of hospital, you know, I think innovation can very much sit at how can we keep people out of hospital? And I think hospitals are a great place to sort of think about how we can keep people out of hospitals, if that makes sense. So health services research is a specialty in its own right, but it supports the other 29 clinical specialties in the clinical research network, especially where there's an element of service organization or service delivery. We have 5 sub-themes of patient experience, workforce development, patient safety, implementation science, and quality improvement. And I think if we again look at these from an innovation perspective and not from a research perspective, although the two arguably feed into each other and very synergistic. But if we look at patient experience, and I think Dawn's presentation really showed how patient experience can impact, and sort of the design and the prototype was built on patient experience. And I also liked in both presentations about how workforce experience, about how yourselves as healthcare professionals came up with an idea. You were looking at what was going on, what the gaps were, and how you could make that better. So I think we've got really great examples of health services in practice through those examples. Also, just sort of feeding that into the Helen McArdle Nursing Care Research Institute, we focus on 4 programs, which naturally is health services research. We look at health inequalities, and again, this is something that has existed, but the pandemic has widened that gap in health inequality. Health inequalities. We look at access and equity of services, and I think innovation is a really good space to be rethinking about what we can do to address that. Within Sunderland, we've got the Healthy City Plan, which is 3 themes of starting well, living well, and aging well, so a real life course approach to health and care. We also have a COVID-19 health inequality strategy, which again, I would urge you, in context of just thinking about how we can do things differently, to be looking at these published documents that are widely available, and again, how we can use innovation to address health inequalities. I've also been involved for years with nursing, midwifery, and allied health professional research, working across the trust and the university, but taking it now into that knowledge exchange space. So again, Don was mentioning about, you know, healthcare professionals not being conversant with memorandums of understanding, intellectual property, and more the commercial sides of research and innovation. Knowledge exchange is a nice safe space to sort of explore those and try and understand them and put them into the context of innovation. At the beginning of the presentation, Tony talked about the 5 faculties within the university. We are big fans and hugely advocate collaborative and interdisciplinary research. Myself with the Institute, we've worked very, very closely with the Faculty of Arts and Creative Industries. And again, sometimes you think that's not sort of a national fit, but the evidence from the World Health Organization to look at the impact of arts on well-being is undisputed. And if you look at social prescribing as an intervention, and again, looking at how do we keep people out of hospitals, how we can provide care, how we can keep costs down, social prescribing is a really new and innovative way of rethinking and integrating health services into mainstream practice. So we've got some great examples going on in the Institute there. And again, I would just say social prescribing now is taking place very much in the community. But I do think, again, there's opportunities within the acute settings to look at how we can start those conversations and anything we can do to implement the facets of social prescribing into the acute environment to have this concept, you know, embedded and established, because it's there, it's not going to go away. It's brilliant. The evidence to say it's working. So I think my sort of call to arms and contribution is, you know, I'm here as the head of the Research Institute, but please don't just think about research, think about innovation. I appreciate it's an emerging conversation, but there's a fantastic relationship between the Trust and the university, and I think all 3 of us are just keen to build upon that. Thank you.
Many thanks. Many thanks. We're happy to take questions. We're conscious of the pressures of times on colleagues, but we'll throw the floor open if there are any questions.
Yeah, Imran.
Thanks, Mark, and good afternoon, Tony, Adrian, and Yitka. Yitka, it's been a while. I haven't seen you. It's really nice to see you there. I believe you know me, Yitka. I don't know if Tony and Adrian. Tony, I think I met you with the TRE discussions. I'm one of the director of innovations here, and also a neonatal consultant. Very nice. Thank you for the overview. I think you will also know that I met John Timmis some time ago. And it's good to see the team you know, we're re-engaging again. Hopefully this time we will keep the momentum going. A couple of things that kind of found really interesting of what you were saying, Adrian, about the pharmaceutical stuff. I'm really wondering, when you were talking about this, whether we should get you to come and speak to specific group of clinicians and staff here, just to see what you're doing. I think that'll be a good idea, just to get people thinking about projects. Otherwise, they won't know what you're doing, and we won't know. And especially when you put out generic meetings like this, often you don't get the attention you need. And really interesting what you said there about some of the microbiology stuff. I worked on a small project with Tim Paget. I haven't seen him either for some time. We did a little bit of looking at surveillance in our neonatal unit, especially looking at bugs on equipment. It was a fairly simple project to do, actually. It was interesting to see, because we have these problems with cleaning equipment in the hospital. It was quite an interesting one. I think that's there's something there. And the other thing I picked up from Yitka particularly was around health and inequalities, which is quite a good topic to continue. I think Ryan Swears, I don't know if you know Ryan, is from public health, and we are engaging with Ryan with the research department as well to see if we can actually collect around the, you know, data in every single research trial that we do where we look at inequalities, health inequalities particularly. It'll be interesting to have another conversation with you as to how maybe the university can help us analyze the data. When we formulate something, I know Claire Livingston's on the call. We've been having chat with Ryan particularly in looking at how we can look at this very specific area especially around the Sunderland. So yeah, thank you for lots of things we can do really, but just getting that engagement on either side, especially with clinicians. And I think getting you guys to come and speak to a core group of interested specialties. I'm thinking about pharmacy. My wife's a pharmacist. There may be something there.
Absolutely.
Just open to discussion.
Yeah, we're absolutely up for that, Imran, for sure. Yeah. To get the get some traction again, I think will be really helpful. It's very, very timely. You have a direct link into Adrian. You have a direct link into Yitka. You know, please don't let anything get in the way. We'll happily do that. It'll be a pleasure.
Thank you very much. Mark, any comments? I think.
Yeah, I suppose we've discussed about obviously any of the innovations that come through South Tyneside and Sunderland would potentially come through the innovation department to be funneled to yourselves. But I'm aware that there's one or two other innovation managers from across the region on the call, and this talk will also be shared with our innovation forum, which I think we've talked about and touched upon, of all the other innovation managers meeting across the region and chatting. So if they had any interest in talking to you, what would you say would be the best way to come through? Would you want them just to be introduced by myself, or would you want to share your email with us and we can share it with them? Or
we're very happy for things to be routed through yourselves. In the early days, the shorter the line of the communication, the more effective opportunities there are to generate something meaningful. So if we route it through you, you can route in through me, and I've said we would respond within 24 to 48 hours.
That's great to know. So I'll share that with our other innovation managers across the region. And while we're wishing everyone good lucks on the awards, it's great to have, you know, Times Higher Education nominated for University of the Year. University just on our doorsteps and yourselves. So good luck on that.
We'll know the outcome tomorrow.
Well, that's what there must be all the award ceremonies on with Dawn, Ala, Phil, and yourselves all waiting for them. So fingers crossed for good news across the board.
Fantastic, and good luck. Yes.
And good luck to yourselves tomorrow.
Well, thank you very much for your time, and thank you everyone. We'll be sharing this, and if there's any questions, you know, do come through the email that Catherine shared on the chat, and enjoy the rest of your day. Thank you very much.
Thank you.
Thank you very much. Take care.
Bye-bye.
Bye.